In the diagnosis of a relapse in MOG antibody disease, we heavily depend on MRI to see if there's a new lesion. That is the evidence of an attack in MOG. And MRIs, if you get them too soon after the onset of the attack, it might not be there yet. And if you get the MRI too late after an attack, it may have already healed. And so you might be missing the lesion if you get the MRI too soon or too late. And so what to do in those circumstances? Well, we still have our clinical judgment. If the attack is very obviously affecting your vision in one eye, that's most likely a relapse. You don't necessarily need to see a new lesion if there's a brand new symptom that has never occurred before. Or if the examination is very, very clearly affected. If you can't move your legs today and you were moving them just fine yesterday, that's a pretty clear indication. So those are two clinical examples. Also, we have spinal fluid testing that requires a lumbar puncture, which is invasive, but it's very sensitive. And so if there is inflammation in the spinal cord or the brain or even the optic nerve, it might be detectable on spinal fluid analysis. And one last thing, if you get the MRI too early, you can always repeat it. I have several cases where the MRI was initially negative, especially in optic neuritis, looking normal, but the symptoms persisted and we had repeated the MRI one day later and it was positive. And so that happens as well.